This is Heart Rhythm TV, and I'm Daniel Alyesh. Welcome to Breaking News. The era of pulsed field ablation for atrial fibrillation is upon us. And quite frankly, the adoption has been at a fever pitch. We're all excited for the new technology. And quite frankly, there's no greater transformative innovation in EP in recent memory like PFA. However, when we've all had a fever, right, we don't think quite clearly. And so I think it's a great time to do a critical appraisal of the cost effectiveness of PFA for AFib as compared with other traditional thermal modalities. And for that reason, I'm joined today by Dr. Dhiraj Gupta. He's of Liverpool Heart and Chest Hospital, and he's a professor of medicine at University of Liverpool. Welcome.
Thank you, Daniel.
He and his co-authors published a very nice article in Heart Rhythm Journal looking at the cost effectiveness of PFA as compared to traditional thermal ablation. So to proceed in our discussion, let's talk a little bit about the study design. A single center tertiary care hospital, a teaching hospital, 7 operators, 774 patients divided amongst the 3 different modalities. I'll ask you to start off here, Dhiraj. What were the main findings of your study?
Yeah, Daniel. Well, essentially, as you rightly said, there was a lot of excitement around pulse field ablation, and we were very lucky to get our hands on it in early to mid 2022. We are a large volume center in the UK, perhaps one of the largest ones, and we decided very early on that we were going to still keep our numbers with thermal ablation going. Some of the centers have moved wholesale to pulse field ablation, as you mentioned. But in our case, we always had one catheter laboratory which was running with pulse field ablation under general anesthesia, and another catheter laboratory through which the thermal ablation cases were going on. So this simultaneous throughput of cases with both pulse field ablation and thermal ablation allowed us to compare our outcomes, our complication rates, our throughput through the lab, our day case discharge rates, and importantly, the costs associated with delivering AF ablation through these 3 different modalities. So essentially, that's what we did. All comers, all patients who underwent first-time AF ablation at our center over this 18-month period, with either of the modalities, we essentially compared their outcomes head-to-head with each other. And what we found was that so acute efficacy was pretty similar between the 3 modalities. The follow-up arrhythmia recurrence rates were very similar. Even the complication rates were very similar, and we'll drill into the reasons why that might be the case, because obviously one of the biggest selling points for pulse field ablation is the fact that it's supposed to be safer because it's cardioselective. So you eradicate the risk of esophageal injury, the phrenic nerve palsies. But what we found overall was that the complication rate was so low. The major complication rate in our study was just 1%. It was almost impossible for any technology to beat that. So our complication rates were similar, success rates, acute and follow-up were similar. But when we drilled down to the costs involved with delivering these procedures, we found that pulse field ablation was significantly more expensive than cryoballoon or radiofrequency. And the reasons for that were twofold. One was the increased consumable costs, i.e. increased catheter costs with pulse field ablation, but also because pulse field ablation, at least in the United Kingdom, needs to be delivered under general anesthesia. Whereas cryoballoon ablation or radiofrequency ablation, we can still do it under conscious sedation using opiate analgesia. So for us, there would be additional costs with general anesthesia as well, but the bulk of the driver for the additional cost was the catheter or the consumable cost.
Very well said, thank you, and a really important analysis that you did. A couple important points I want to make, right? I always say that, for a change in EP to actually gain traction, it needs to accomplish at least one of 3 things, right? It needs to make the procedure more efficient, more efficacious, or more safe. For something to transform a field, it needs to accomplish at least, ideally, all 3, right? And your point is well taken, right? We've spent a long time refining thermal ablation, a long time. You being a pioneer in that as well. And, our complication rates are 1% or lower. And so, the safety the safety benefit of PFA is to avoid catastrophes, at least in the immediate term. I mean, this is our first generation of tools.
True.
And you didn't see any of those catastrophes, the fistula being the big one, right? Phrenic nerve palsies you did see, especially in the cryoballoon arm, but not in the RF arm. So I think that's a very, very important point that you made. Additionally, I think I want to point out important cost differences that you allude to. I think in reading your paper in detail, right, first off, you're not using intracardiac echo across any of these. And I think, I think that's very different than our American practice. And I actually think that this is the fact that there's a cost barrier for a country like the UK to use ICE, I think is a bit of an indictment of where we are as far as being able to offer ICE and the cost. So I want to make that important point. Additionally, you're not using a mapping catheter. You're not using a mapping catheter across the board. You're only using mapping in RF. So
Correct.
Right off the bat, you see a very interesting and tremendous cost difference across the different modalities with a lower cost procedure than we do here in the US. So I want to make that important point. Across the board, looking at your efficiency markers, we're looking at about 20 minutes for PFA relative to the other modalities, correct?
Correct, yes.
And this is your first year and a half of using the PFA system. And so tell me a little bit about, the learning curve day one to day. I mean, first off, what an ambitious study to do this in your first year and a half. But tell me about day one to 18 months later, what that looks like, and will that curve continue to bend with PFA?
Well, those are very good points, Dan. I think the learning curve with pulse field ablations or the FARAPulse system that we've used for this study is very shallow. It's incredibly quick to be good at this. And you only need to do, I don't know, a dozen cases and you're really flying. That's one of the biggest selling points of this technology as well. So although we have seen that our procedure times have continued to reduce, I will tell you why in a moment, why that has plateaued, or if anything, the procedure times have increased of late, and I'll tell you why. See, as you said, the three important things that we have to bear in mind when we're comparing technologies are efficacy, safety, and efficiency. Now, with pulse field ablation, the safety was the biggest selling point for all of us because, as you said, fistula, very rare, but when it does occur, it's catastrophic. And we really want to avoid that, especially when it comes to an elective procedure like AF ablation. Clearly, a study which is only 700 patients wasn't large enough to pick up that difference in this rare complication. You would need tens of thousands of patients really in a study to be able to show that difference. But what you cannot study in a study like this is the feeling of comfort that you have when the patient leaves the hospital, then you know that the patient will not have a fistula. Or when the patient calls you back after a week complaining of a bit of chest pain and you're thinking, is it just pericarditis or is this something more sinister? So obviously this study was not designed to study those kind of endpoints. But definitely in terms of safety, when it comes to experienced centers like ours, like yours, I think it'd be very difficult for pulse field ablation to show any safety advantages over thermal ablation. When it comes to efficacy, sorry.
Go ahead, please.
Yeah. When it comes to efficacy, once again, as you know, even in the Advent randomized trial, there was no difference in efficacy between pulse field ablation and thermal ablation. And to many of us, there you go. And that was the Kaplan-Meier curves for our study. But if you can look at the Kaplan-Meier curves of the Advent trials, were pretty similar, weren't they? And that is a big disappointment for us and for a number of us who really felt that with the durable pulmonary vein isolation rates seen in the pre-market approval studies would translate to really good success rates. And there can be several reasons why that has not been the case. I personally think it's because we're not really using pulse field ablation as well as we can do. We're not using 3D mapping, for instance. As you alluded to, we're not using intracardiac echoes. We're not really sure about the contact. We are using very much, cheap and cheerful way, if you like, of using X-ray and electrograms. When both of those have limitations, as you would know, and obviously as all the listeners to this podcast would know. So this is just the flaw of what is possible with pulse field ablation. I'm pretty sure, as I'm sure you are, that the success rates with pulse field ablation can only go up. Then that brings us to the last thing, the efficiency. Yes, it is 20 minutes faster, but if we are going to start using 3D mapping more with pulse field ablation, as probably we should, if you have to improve these Kaplan-Meier curves, then some of those efficiency gains will be lost, and we'll be back to the same. We will lose this 20 minutes that we are saving. So that's the kind of dilemma that electrophysiologists will have. I believe that efficiency is the least important of the three, safety and efficacy being the more important considerations.
Completely agree with you. I always say, right, nobody shakes your hand at 2 or 3 months post-ablation, says, thank you for doing my ablation so quickly, right?
Correct.
I think that all your points are well taken, right? The current first generation iteration of PFA is a huge innovation forward, but also a little bit like going back in time, right? Your fluoro times, on your PFA procedures are pretty similar to your cryoballoon and well above your RF in your study. And, as somebody who is fluoroless and fluoroless with PFA, I believe there's a huge benefit to operators, staff, and patients to not use radiation. In this case, right, radiation is not therapeutic to the patient. And in any case, it's probably the opposite. It's diagnostic. And we have other, quite frankly, better diagnostic tools. Now, I think the argument for using fluoro and not using these other two tools or other tools, mapping, ICE, is purely economic. And but economics matter, right? I mean, as a global EP community, where I'm speaking to you in Europe, I've spoken to others in Latin America. I mean, the economics of this are significant. And, we need to think about that, and we need to figure out how we can take these practices and make them more widely available. And I think time will do that. I also want to piggyback on your point, right? This psychological burden of worrying about a fistula, myself included, when I do a PFA, that is lifted, even though it's so rare. It's been a psychological burden that operators have carried that PFA has really helped alleviate. And I think that's a big deal. I think that factors into the widespread adoption, even if your point well taken is we're preventing catastrophe. A study like this isn't even large enough. And it should be a very rare event, but really when it's such a catastrophe, it should be zero. And so I think that's where that safety argument comes. Dhiraj, I want to take you to another place, right? You're a teaching center. Tell me about, now that we're using much more PFA for AFib as opposed to point-by-point RF or cryoballoon, what does that mean for trainees and catheter skills and overall training in the future?
That's a very good question, very relevant point, Daniel. I think, first of all, I'll have to say off the bat that it's a very exciting time for trainees to come into EP, to consider coming into EP. We are in such an exciting, we are at the cusp of such technological advances. We've got so many different mapping modalities, ablation modalities. So for any EPs who are considering a training in EP, or any trainees who are considering coming to EP, please do come. It's the fantastic, fantastic specialty. Now, having said that, I do have some concerns about the loss of catheter manipulation skills that the single shot technologies will result in. It's inevitable. The kind of procedural volumes that people of our generation did when we were training, hundreds and hundreds of focal RF cases, that's just not going to happen anymore. And that's part of the reason why we, as a training center in the UK, have retained a large number of radio frequency ablation in our case mix, because we feel we kind of owe it to the trainees to pick up the skill, because otherwise that skill will never be gained. There's going to be a nice compromise, I think. There are some PFA tools which are in the pipeline. Some have even been approved for use in Europe, which are not single shot, so which are large footprint, but still focal technologies, which will allow the trainees to map, to appreciate 3D maps and to use manipulation and navigation within the 3D maps to get to where they want to be. So I think there is a fine balance to be struck, but that balance will find its way within the next few years.
Yeah, I agree. And I think your points actually take me to my next question, So the current first generation of PFA tools, right? They're mostly designed for PVI, right? Just yesterday, I had a case where I ablated a PVC and did a CTI and did a PVI, right? That, that procedure still, I think, in the current stage requires some sort of point-by-point customizability, so it's not going away, right? The current first generation of PFA tools, we can't generate a high-density map with it, right? It's integrated in the EnSite system, but I think the journey for integration also continues. So tell me, it delivers PFA energy, but not a dual energy system. So tell me which, you alluded to the future offerings for PFA. Which offering or what kind of offering are you most excited to see?
Okay, so you're asking me to do a bit of crystal ball gazing now, aren't you? Well, the good news
Here
is
we
that
are.
it's not really all crystal ball because we can actually see these things in the pipeline. First of all, one of the biggest concerns I have with pulse field ablation as it stands now, and I think you've alluded to that, is the X-ray exposure. In fact, your lab has been one of the pioneers in getting rid of X-ray from the EP lab. So I think we really ought to focus on those technologies where 3D mapping will allow us to reduce or eliminate fluoroscopy. And as you know, there are systems in the pipeline. Of course, Affera is there with Medtronic, but also Bios and Webster have their own VeriPulse, and then OmniPulse is on the way, where you'll be able to use 3D maps and hopefully reduce or eliminate fluoroscopy altogether. So there's a great deal of excitement in my mind for that. But the second thing also is, again, you alluded to that, is the lack of versatility with the current PFA catheter. It allows you to isolate the posterior wall in addition to pump the veins, but perhaps that is it. Even in our study, about, I think, 10% of our cases ended up requiring cable trackers peristaltic ablation. And we had to open up a brand new radio frequency catheter for that. And that obviously added to the cost even more. Whereas the humble radio frequency catheter has that versatility. You can use it pretty much wherever you want to. Now, in the next generation of the catheters, which are capable of both pulse field ablation and radio frequency, you don't need to open up a separate catheter. You'll be able to do pulse field ablation on, pump the veins, posterior wall. You'll be able to use radio frequency, if you like, for the mitral line or the flutter line. And that really will enhance the appeal of pulse field ablation and also increase the type of patients we can offer pulse field ablation to, perhaps persistence, long-standing persistence. You may not need to do mitral lines, for instance, or you may not need to do ethanol ablation, for example, because you'll get durable mitral block with just these technologies.
So what I'm hearing, which is something that resonates also with me, is some sort of middle footprint, ability to map, customizable, dual energy device moving forward makes us all really excited. I think that also you made an important point, right? In the world of RF, we could control our power, we could control our duration, we could control our force, and we could control our irrigant, all designed to give us a different kind of lesion. Now we're left with how many times we push the button and how good is our contact. And I think, moving forward, electrophysiologists, we're also our scientists, right? And so moving forward, we want to be able, we would love to, I think, I'm going to editorialize myself, we would love to have a little more control over how do we deliver the lesion and remove that kind of veil of proprietary algorithms. So I hope to see that moving forward as well. So in conclusion, right, your study showed a very, very well done study. I appreciate it. And what we saw was human capital, right? Requirement, lab time, operator time went down with PFA, right? And despite those changes, which reduced the cost of the procedure, the cost of the equipment completely offset those changes and increase the cost. And this is in a lower cost model that you do in the UK relative to what we're doing here in the US. So final point, the economics around the cost of the disposables, the cost of the catheters. As more come to market, what do you see as far as driving that tangible economic strain related to those costs of the durables?
That's the million-dollar question. Literally, it's a million-dollar question, isn't it? What's going to
The gold
happen with the
rush. Yeah.
cost? Exactly. So as of now, there's a lot of excitement amongst EPs, understandably. So a lot of hype amongst patients, and clearly, we are going to have to pay through our nose for that excitement and the hype. So we will have to pay premium prices for that. Having said that, I'm optimistic that once many players enter the market forces themselves will come to play and will drive the prices down. There'll be competition. So hopefully we will be seeing keener pricing compared to what we've been seeing so far, because it has to be the case, way forward, Daniel. I mean, AF ablation is as you know, the numbers are just going exponentially high. And we cannot really break the bank on the back of just one procedure. The NHS, I can tell you, I'm sure the US health system, we have so many different conditions to treat, and there's so many different ways to treat it. And I think we all have to be mindful of cost. And every decision we take as EPs does have a bearing on the bottom line.
I completely agree with you. The 2023 guideline for AFib talked about the impact of ablation on the system. And there are data showing that it benefits the entire system. There are data that show otherwise. I mean, so it's kind of, I think overall, the sense is that it does benefit the system by reducing hospitalizations and better managing AFib. But now if we add this new cost element, that changes our whole calculus. And we have to think about the entire system. And I believe the market will help us here. Well, thank you very much, Dhiraj. A great study. Thank you for joining me.
Well, thank you very much for having me. And it's been an absolute pleasure.
And thank you all for tuning in to Heart Rhythm TV.